a surgery which actually is targeted at the pathology, and the results have been exceptionally satisfactory. The only thing, of course, is that the patient selection has to be spot on. If it's not so, then you will end up with undesirable results, and I think that is why we need to know exactly when you will do the UKA. So I just want to make one or two opening statements. The first is that please do not look at unicondylar arthroplasty as a pre-TKR. It's not a pre-TKR. It's a treatment on its own, and it has its own survivorship. So that's the first thing. The second thing is that please do not connect the age of the patient with the procedure. So please do not have the idea that this is for young people and not for old people, and that. In my opinion, the best patient to start with, I would say, is the elderly male patient with medial compartment arthritis. Now we will see what are exactly the technicalities of the indications. So this is meant for what is called the anteromedial osteoarthritis, and here the ligaments are functionally normal, and I think that's the basis of this surgery, that the ligaments are normal, and therefore you do not actually do any procedures on them. The criteria for diagnosis, it's medial arthritis with bone on bone. ACL and MCL should be functionally intact. The cartilage thickness on the lateral side should be normal, and we will see how we can actually make these diagnoses and decide to proceed with the case. Now, this is an extreme case. Now, anyone looking at this would say that this is a patient for a total knee. But if you notice, then the cartilage on the lateral side is pristine, and the ACL is intact, and the cartilage at the posterior part of the medial compartment is intact. So as far as I'm concerned, it fulfills the criteria for a unicondylar knee replacement. Now, just of the specimens which were removed at surgery, and you can see that the extent of arthritis in the anteromedial compartment can be variable, but what is constant is that there is a little bit of posterior cartilage maintained in the medial compartment, and we shall see the importance of this. This is the arthroscopy picture of early anteromedial OA, and by the way, pre-operative arthroscopy is not required in this procedure for deciding upon a UKA. So this is the arthroscopic pictures that you get to see. Now, what is the pathophysiology? This is the outline of the knee, and what you see here is that the blue shows the preserved cartilage, and the lost cartilage is in red. Now, this is what happens. The cartilage in the anteromedial compartment is gone, the posterior part is intact. So then what happens is that the medial collateral ligament becomes lax, and the knee sinks into varus, which is pronounced in extension. But what happens when you flex the knee? When you flex the knee, then the intact cartilage in the posterior part of the medial compartment comes into play, and then the medial joint gap is restored, and the medial collateral ligament becomes tight. So, which effectively means that the MCL length is actually preserved. Now, this is true as long as the ACL is intact. So this is essentially a correctable varus deformity. So this is the correctable varus deformity. In extension, it sinks into varus, but when you stretch it out, it gets corrected. The ACL is intact. Now this is essential for the deformity to be correctable and the MCL to be non-contracted. So there you see the medial collateral ligament becomes lax when the eroded portion comes into play, but when the intact cartilage comes into play, then the MCL is restored. But what happens is, once the entire cartilage is gone, then even in flexion the MCL is shortened, and then the MCL has a chance to contract, and then these cases become unsuitable for doing a UKA. You see an extreme example here. Anybody would say that this would require a total knee. It looks quite bizarre, in fact. But now, when you do a stress X-ray, you find that the joint actually opens up. This tells us that the MCL is intact, it is not contracted, and the posterior part of the cartilage is intact. So this qualifies for an AMOA. And the radiological evidence of intact posterior cartilage on the medial compartment of the tibia is the preserved bone that you see posteriorly in a dead lateral X-ray. So this is a very important X-ray to be taken while making the decision for going in for an AMOA. So what are the diagnostic criteria? It is medial osteoarthritis, bone on X-ray, particularly in the standing view. The ACL should be functionally normal. MCL should be functionally normal. The lateral compartment should have full thickness cartilage, and these are the criteria. How do you diagnose it? So the basis of the diagnosis is an X-ray and not an MRI. So the stress radiographs are important, and they are recommended, and it's helpful to make these other diagnostic points. And all of this, of course, is confirmed intraoperatively. So how do you do an X-ray? It's the so-called Rosenberg view. The patient is in supine position, knee flexed at 20 degrees. The beam is angled at 10 degrees to be parallel to the joint line. And then the patella should not be rotated. And then you apply varus and valgus stresses. So this is how you position the patient with a wedge under the knee. This is how the X-ray beam should come. And the surgeon applies varus and valgus stress. Now, when you look at these ideal stress X-rays, the patella is central and not rotated to one side, because that will give you a fallacious view. The joint line should be parallel. You should not see two surfaces there. 20 degrees flexion allows the deformity to correct as it relaxes the posterior capsule, because when it's in full extension, the posterior capsule is tight, and that comes into play. And just short of the FFD. So then you apply the varus stress and the valgus stress. Now, when you look at the varus stress X-ray, you have to see that there is a complete loss of cartilage, and there's a bone-on-bone contact on the medial side. And when you look at the valgus, then with full valgus stress, there is a joint gap which is preserved on the lateral side, and therefore this tells you that the lateral compartment is intact. Now, a functional normal MCL correctable intra-articular deformity can be demonstrated with the valgus stress X-ray, normal opening on the medial compartment. But the overall alignment, even if it's in a little bit of varus, it should not matter. How do you know that the ACL is intact? The lateral X-rays must be perfect. So your medial and lateral femoral condyles must overlap perfectly. That will tell you that the lateral X-ray is accurate. And it's in fact 95% indicative that the ACL is intact. This is, if you look at it here, the posterior part of the tibial condyle is absolutely intact there. And here, when you see the red line shows you the joint line, when it is involving the posterior part of the condyle, then this tells us that the ACL is involved, as you can see in the lower two X-rays. So this is again a very, very important test. Intraoperative ACL assessment, this is somewhat controversial. A lot of people, when they see the ACL is not that good, they convert to a total knee. But what the literature says is that, and it's been a multicentric study, is that even if you have a little bit of friable and fragmented ACL, or in synovium a little bit damaged with longitudinal splits, it is still acceptable, and you can go ahead with the. Now this is applicable for a mobile bearing uni, by the way. If you're planning a fixed bearing uni, then possibly even with a compromised ACL, you can still go ahead, provided your MCL is intact. Now, clinical assessment, one must be careful, because your ACL may feel stable because of osteophytes, so watch out for that. Look carefully at the X-ray. The ACL may feel unstable if your bone loss is significant, and the MCL may feel short with the tibia varus. But this is just you should watch out for this. The MRI is not really recommended, because the ACL may appear intact. You can get false positives and false negatives. Arthroscopy is also not recommended. So what is the real diagnostic criterion is the X-ray. So in summary, anteromedial osteoarthritis, full thickness medial loss with varus stress on X-ray, functionally normal ACL, lateral, you diagnose that with the lateral X-ray. Functionally normal MCL, you look at it with the valgus stress X-ray, and full thickness lateral compartment, which is again by the stress X-ray on the laterals of the valgus stress X-ray. Just one more point, that what about the patella? Now, if there is a significant lateral patellar facet arthritis, then it's a contraindication because they can get anterior knee pain. A medial facet osteoarthritis is not a contraindication to go ahead with an ACL. I thank you for a patient hearing.